Okay. Hello, testing, everyone. Hopefully you can hear us now. Hopefully there are no sound issues now. Thank you very much. So, hello and welcome to this session of Norfolk State University's Black History Month celebrations, contemplations, discussions, contributions. As you guys know, the theme for this year is Black health and wellness. And unfortunately, the pandemic, I think, and recent politics and all of that has shown a spotlight on the fact that this is so important. It's so important for us to continue to focus on health and wellness. So I'm Dr. Felicia Mebane. I'm the executive director of the newly formed Center for Public Health Initiatives at Norfolk State University. And when Dr. Khadija Miller asked me to participate in this session, I was super excited. Because again, recent events have shown what I learned years ago as someone who was trained in public health, that we need to be cognizant of what's driving health outcomes and why there are differences between groups of people, why Black and Brown people have different outcomes. And very specifically around the center of the topic that we're discussing today, racism and disparities, or flipping it around, centering health equity and centering health equity. So I am super excited, anti-racism and health equity, there we go. So I am super excited to join our special guest for today, Dr. Oni Blackstock. I have to tell you, I am totally fangirling. I follow her on Twitter. I encourage you to follow her on Twitter. She is totally awesome. So I am very excited to have this conversation with her today. And speaking of conversations, we want you to know we do want this to be something that is engaging. We want you to participate. And so the format is going to be Dr. Blackstock's going to talk with us about her background and experience and share insights. And then we're going to have a chance to open the floor for you guys to ask questions, to share your thoughts. I'm going to ask some questions, share some thoughts, and so we'll have some dialogue and discussion. So I'm going to turn the floor over to Dr. Oni Blackstock to talk about centering health equity and anti-racism. Thank you, Dr. Blackstock.
Thank you, Dr. Mebane. And good evening, everyone. And thank you so much to Dr. Miller for the invitation to speak as part of this Black History Month series. We know that this is Black History Month, but we know that really every day is Black history in the making. And so I'm happy to share with you a little bit about my background and my path to promoting racial equity within the public health arena and within healthcare. And I look forward to the Q&A. And so I'm just going to go just an overview a little bit about my background and so how I came to really be focused on these issues. So I'm just kidding. Okay, great. So just when I think about how I've gotten to where I am, I think about those on whose shoulders I've stood. And I think, most immediately about my parents. So I grew up in Brooklyn, New York, and I just found out not too far from where Dr. Miller grew up. So I grew up in Brooklyn, New York in the 80s and early mid 90s on the border of Crown Heights and Bedford-Stuyvesant. And that's my father there on the left-hand side. He immigrated from Jamaica and came to this country on his own when he was 17 years old. He worked a variety of jobs as a cashier, a bank teller, a refrigerator mechanic, a janitor. It kind of reminds me of that In Living Color sketch of like Jamaican people having like multiple jobs. So that's basically what he did. He ultimately joined the Army and on the GI Bill ended up going to community college in New York City. He then moved on to one of the city universities and then got his MBA at Baruch College, which is one of our other city universities. And basically he was an immigrant who was a product of the public education system in New York City and ended up spending most of his career working as an accountant for the Department of Education. My mother, who is there with my father in that middle picture and holding my twin sister and I in that lower right-hand picture, she was born in Brooklyn. She was Brooklyn born and bred like myself. She was raised by a single mother along with her 5 siblings on public assistance. And she overcame a number of barriers to attend college, becoming the first person in her family to do so. She ended up going to medical school and spent most of her medical career working as a kidney specialist or a nephrologist in central Brooklyn at Kings County SUNY downstate hospitals, taking care of patients in the very neighborhood in which she was raised, and spent a lot of her time doing community health and health advocacy. In addition to this, my parents really instilled in me a strong sense of service to my community and the importance of the values of equity and social justice. And so from a young age, we participated in protests as a family, demonstrating against police brutality in New York City, as well as against South African apartheid, and protesting for the release of Nelson Mandela, who was imprisoned at the time when I was a child. And I've continued this tradition. That's the picture of myself with my dad on the left-hand side at a Stop Racial Profiling protest here in New York City, and then with some colleagues supporting healthcare reform during the Obama administration. And then on the right-hand side at the Women's March with my kiddo, who, despite looking somewhat excited in that picture, had a tantrum soon after all the snacks ran out. And I don't really bring him to marches anymore. But anyway, a passion for social justice was one of the really influenced my mother's reasons for going into medicine. And she was, like myself, also guided by her own experience of growing up in poverty. And this quote by Rudolf Virchow, who was a 19th century German physician who was known for really promoting public health, really, I think, really highlights and illustrates the role of healthcare providers as advocates. It says, physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. My mother, there she is on the left-hand side, realized the ways in which poverty and health were inextricably linked. And this connection really led her to focus on community health and advocacy. And so much of my childhood was spent with her and my sister at community health fairs throughout New York City, where she educated people about high blood pressure, kidney disease, conditions that disproportionately impact Black people. And so while I majored in computer science when I was in undergraduate, I was also pre-med and had every intention of going to medical school and following in my mother's footsteps. And it was while I was in college, when I was pre-med on this path, that life happened. My mother was diagnosed with a rare form of leukemia at the age of 46, and she was given 1 month to live, but she persevered and lived for an additional 8 months before succumbing to this disease. And 47 at the time seemed really old at the time when I was 19. But now I'm only 3 years away from that age, and I realized, how young and how scared she must have been. After she died, my sister and I found a letter under her mattress that she had written to us. And in it, she asked for us to take care of each other, to take care of our dad, who's in that picture on the right-hand side, our aunts and uncles, who were her brothers and sisters, and to continue our path to medicine. So the picture on the left-hand side is our mother at her medical school graduation. And then the picture of my sister with our dad was 30 years later. We graduated from the same medical school, Harvard Medical School, that she did 30 years later. And so we had achieved, her dream for us and our dream for ourselves. And, my mom's time at Harvard Medical School was very challenging. She felt like a fish out of water. Many of her classmates, their parents were professors or also doctors. And my sister and I, we had a very different experience. Having had a parent who was a physician, we found friendships, we found mentorship and support. And for me, medical school was where I, quote unquote, discovered HIV. I became really intrigued with HIV as both a biomedical condition as well as a social condition. And so I started medical school in 2000, about more than 2 decades ago. And that was a time where there was a great investment. There was a global fund that was a fund to fight HIV, TB, and malaria. And many countries in sub-Saharan Africa at the time were being ravaged by HIV. And we're now receiving an infusion of funding for HIV treatment. And so I traveled to Durban, South Africa. For me, it represented, really the fight for human rights, really to work there at a hospital, at a palliative care center for people who are dying from HIV. I also traveled to Ghana in West Africa to work at an HIV clinic to learn more about the factors impacting medication adherence, or the ability of people to take their medication, and specifically looking at people living with HIV. And the clinic, as you can see on the left-hand side, was actually literally located outside the perimeter of the hospital's campus. It was really marginalized in the same way that many of its own patients had been marginalized by their families and by society because they were HIV positive. And while I had gone there to study HIV treatment adherence, I was really drawn to understanding the drivers of HIV infection. And there I really witnessed firsthand the ways in which poverty and patriarchy and gender inequities and stigma work to perpetuate the spread of HIV. And I also saw, on one hand, how families could love and support their family members living with HIV, but I also saw the ways that people with HIV were stigmatized and ostracized, and eventually wrote an article about HIV stigma and how it was a barrier to HIV treatment for many people. And this was based on a young woman I met who was living with HIV with her daughter and was made to live in one room of her family's house. She was forbidden to enter the kitchen or the bathroom for fear that her family members would contract HIV from her. So I was still in medical school when I returned from that experience in Ghana, really feeling motivated to understand what was going on with HIV here in the United States and here in the very communities and community in which I lived and that my friends and family lived. So while I was in medical school in Boston, I ended up doing an HIV elective back home here in New York City. I'm working with an organization, the Community Healthcare Network, that had community healthcare centers throughout New York City and primarily in the most impoverished neighborhoods in New York. And I saw so many parallels between my experience in South Africa and Ghana and what I saw working in central Brooklyn, in Harlem, and the Bronx. The same thread of stigma, marginalization, disenfranchisement ran through these seemingly disparate communities that were located in two different continents. And so wanting to pursue HIV prevention and treatment after medical school, I chose to train in residency in primary care, internal medicine, because for me, of all the specialties in medicine, this one really focused on preventive health, on really keeping our patients healthy. And my first choice was to go to Montefiore Medical Center, which is in the Bronx and has a really unique training program focused on primary care and social medicine and a really holistic approach to taking care of patients, to really understanding how one's social context influences their decisions, their choices, and health outcomes. And it was interesting, coming from Harvard Medical School, I had a faculty member who I considered a mentor say to me, well, why would you leave the Harvard system? Why are you throwing in the towel? That's what the person said to me, because I was wanting to go back to New York to really work with my community. And so it just reminded me that, you know, in life, it's really important to make sure that you take advice from people who have been brave in their own lives. And this was someone who had not been. So I disregarded their advice and I decided to rank this program the top program for me. And I was really grateful that I did that, because I learned so much about HIV primary care. I was able to form long-lasting relationships with my patients. And the experience really further inspired me to get more specialized training in HIV. So I ended up pursuing, after residency, a one-year HIV fellowship at Harlem Hospital, which was the same hospital actually where my mother did her own medical residency 30 years prior. And Harlem Hospital, as you may know, has trained generations of Black doctors. And I was really grateful to have this opportunity. I really threw myself into my clinical work, into learning from my patients, learning about their lives. And I had a lot of questions that emerged from my conversations with my patients, like what factors affected whether my patients showed up at clinic, what factors affected whether they took their meds in the morning, how effective were the programs that we were running. And so at Harlem Hospital, I had a chance to evaluate a new rapid HIV testing program that was in their dental clinic. They actually had a HIV testing counselor who was embedded within their clinic. And it's interesting because studies have found that people who are at high risk for HIV we're more likely to see a dentist than a primary care doctor. So in many ways, dental clinics were the optimal place to provide HIV testing. I also did another study. I was interested in the relationship between patients and their providers, and I was aware of the role of medical mistrust that many of us have due to the racism that we experience. So I conducted a study to understand the relationship between trust in one's provider and one's adherence to HIV treatment, and found that yes, trust in one's doctor is associated with whether someone takes their HIV medication or not. And these findings were important because they emphasize the importance of the patient-provider relationship in HIV outcomes and disparities. And we've heard a lot about medical mistrust during this COVID-19 pandemic. And much of the research around medical mistrust actually is based on research within the HIV field. And while these projects I learned a great deal, I realized that I didn't necessarily have the tools to continue to ask and answer these questions in a rigorous and systematic way. So in order to acquire the tools that I needed to be a researcher within the healthcare and public health spheres, I went to the Robert Wood Johnson Foundation Clinical Scholars Program at Yale, which is in Connecticut. And I partnered with community-based organizations and community leaders, some of whom are in that picture, to answer questions of interest and relevance to their communities. And I practiced something called community-based participatory research, where our community partners are equal partners in research and really conceive of the research questions. And we partner throughout the research process to address questions that are of interest and great relevance to community. I also had the opportunity to choose a leader in healthcare and public health that I wanted to shadow as part of a leadership seminar. And I decided that I wanted to shadow Dr. Monica Sweeney, who's in the picture that you see. She was assistant commissioner at the New York City Health Department at the time, and she was leading the city's response to the HIV epidemic. And so I shadowed her for a few days and thought she had the most exciting and interesting job. And I'll come back to why I mention her a little later. So after my research fellowship at the Robert Wood Johnson program, I wanted to continue practicing clinically as well as doing research in HIV prevention and treatment. And I had no doubt where I wanted to go, which was back to Montefiore. And the reason why was because many of my patients were still there, but also because I had a mentor, Dr. Chinazo Cunningham, who's a very accomplished researcher in the field of HIV and substance use. And mentorship is really critical, particularly for Black people, but for everyone within the field of research and medicine. If you don't have a mentor, it's very hard to find success to get to the next step. So I went back because I knew I would have someone who was right by my side who could help me out. I also wanted to work with like-minded colleagues who wanted to be in the Bronx, figuring out how to address health inequities. During my first year back as faculty at Montefiore in the Bronx, Truvada, which was an HIV medication, was approved by the FDA for use as PrEP. PrEP is a once-a-day pill to prevent HIV infection. And given the known disparities that we know exist with HIV infection, because most people impacted are Black people and brown people, I knew it was imperative to make sure that we were getting this medication to Black and Latino men who have sex with men, especially particularly those who were young, who may not be aware of PrEP and who didn't have access to it. We knew the same factors that drove disparities in HIV outcomes, racism, homophobia, lack of access to culturally competent providers would drive disparities with PrEP access and uptake. And so I became a provider in this Engage NYC program at Montefiore, which sought to link young Black and Latino men in the Bronx to PrEP and to primary care. And we posted advertisements everywhere online so that we could get folks, get folks connected to PrEP. PrEP I also saw as an entry point to primary care. And I saw this when there was a young man who came in through the program who was maybe 30 years old. He didn't have any known past medical history of anything that he was aware of. And he ended up coming in for PrEP, but we also diagnosed him with high blood pressure. And we were able to get him connected, not just to PrEP, but to primary care. And as usually the case, one question begets another as we began to treat more and more young men who were coming in for PrEP. I noticed that we weren't seeing many women who were coming in asking for PrEP. And so I turned to advocacy really to raise the alarm or raise awareness around PrEP. I found collaborators to work with to get the word out to women about this medication, especially for Black women who account for about 60% of new HIV diagnoses. I wrote op-eds about the need for Black women to know about PrEP and to have access to it, and to know that this is a sexual health tool that was available to them. I gave talks at community-based organizations, and I knew that as a healthcare provider, many times, whether I deserved it or not, people would listen. As a result, I also ended up, through my research, developing a program to reach women who were at the margins, to link them with health and social services that they needed. I collaborated with the Washington Heights Corner Project and New York Harm Reduction Educators. These are organizations that provide harm reduction to women who may be using drugs or injecting drugs. And we use their model of providing care, street-side care, to have women, to provide information to women about PrEP and link them to PrEP care at a local clinic. And this was literally meeting women where they were. And for me, this is the work that really is the most meaningful, that reaches people, that is culturally responsive, and that really addresses the needs of community. So over the next several years, through my clinical work and through my research, I became involved in many citywide and statewide efforts to end the HIV epidemic in New York City. And these experiences really gave me perspective beyond the four walls of my clinic, and beyond the often very controlled nature of research, where one really can't deviate from certain protocols. And so my work really began to intersect with the work of the New York City Health Department. And I was meeting a range of stakeholders who were equally as passionate as I was about ending HIV. And I realized I wanted to be involved in work that had a large scale impact, that didn't have to wait for research findings to be integrated into clinical practice. It often takes about 17 years for research findings to be incorporated or implemented into clinical practice. That was just way too long for me. And it was around this time that I happened to get an email from a friend who said, the assistant commissioner position at the Bureau of HIV at the New York City Health Department is available, and that you need to apply. Someone like you needs to be in this role. And this was the same role that I had shadowed 7 years prior. Dr. Monica Sweeney had the same role, and she was leaving. And so I decided that this was a really exciting opportunity. And I wanted to work with an organization or an agency that was at the forefront of public health, where there were still opportunities to build and expand on the amazing work that was happening, and to do this work in my own hometown. And so I applied and was selected to be assistant commissioner at the New York City Health Department to oversee the HIV epidemic. And I was one of the few Black women in a leadership role at the New York City Health Department, which had its own challenges. And so I took on this role with lots of enthusiasm and lots of excitement, and found it was a tremendous responsibility. I was now leading a 300-person department with a more than $100 million budget. I had many sleepless nights, but we were making a big difference. As I mentioned, HIV has some of the starkest inequities. In 2019, 75% of all new HIV diagnoses in the US were among Black men, most of whom are Black men who have sex with men, and also Black cisgender and transgender women are also disproportionately impacted. So much of my work at the health department was really addressing and centering equity in all of our programs. Many times public health programs are addressing the impacts of racism, of homophobia, but they're not doing anything to disrupt racism and homophobia. And so I created the health department's first racial equity and social justices program. My supervisor, who was a white man, wasn't necessarily supportive of my racial equity work, but he didn't stand in the way of it. And so I was able to move a lot of work forward, including bringing equity to the process that we use to give out funding to community-based agencies, prioritizing organizations that were led by Black and Latino people and that were serving Black and Latino people. At the same time, I was really excited about many of the programs that we were implementing. We implemented some really exciting programs delivering HIV testing and condoms to people's homes, developing guidance during the pandemic. However, I realized this was a 24/7 nonstop job. When the pandemic hit, I was serving in my capacity as assistant commissioner. I was also serving in a leadership role for our health department's pandemic response. And it was very stressful, and it was not sustainable. And even though I was getting a lot of work done, developing a lot of programs, I did not always feel supported by my supervisor, and in many ways felt undermined by them. And so I over time became somewhat disillusioned with my ability to move work forward at the health department. And my sister at the time, my twin sister, she had started her own racial equity, health equity consulting firm. And my partner at the time had done the same and said, you don't need to stay here somewhere where you're not being supported. And so 5 months into the pandemic, I left the health department. I didn't have a job lined up. I had some savings, but I knew I wanted to do something where I had control over my own schedule, what I did, that I wasn't muzzled. I often could not speak on the city's policies. For instance, Mayor de Blasio, who was the mayor at the start of the pandemic, was making a lot of decisions that were not based in public health. And I was unable to speak out against that because I was part of the health department. I no longer wanted to be muzzled in that same way. And so I ended up taking the next 6 months to really reflect on what I wanted to do. And that time allowed me to really conceive of Health Justice, my racial and health equity consulting firm. And so the mission of Health Justice is to help healthcare and public health organizations center anti-racism and equity within their organizations and to reduce health inequities in the communities they serve. So the idea is that if we are centering these values within organizations, they will have a ripple effect to the work that they are doing in their communities. And my vision for this organization was really to create a world free of all systems of oppression, where every human being and community is fully supported in achieving optimal health and well-being, and where health inequities are non-existent. And so Health Justice recently celebrated our 1-year anniversary, and it's been a really magical experience, really challenging to see something just start from an idea and really come to fruition. We provide lots of racial equity trainings to healthcare and public health organizations. We also conduct organizational equity assessments, which are really looking at the organizational culture, policies, and practices of organization, and providing recommendations for how they can embed equity within their organization. I've also had a chance to pursue my advocacy. Those are some pictures on the left at a global, I do a number of global vaccine equity actions. So I'm speaking to bring awareness to the fact that there are many parts of this country the world that don't have vaccine access. I've also been able to do a number of media appearances with my sister, where we're calling attention to racial inequities in the COVID pandemic, and then also writing a number of op-ed pieces, really centering and prioritizing the health of Black communities and other communities of color in this work. And it's been really thrilling to pave my own path and to do work that I'm passionate about, and to see what the future holds. I know this is just the beginning, and to hopefully have some level of impact on reducing and eliminating the health inequities that are so pervasive in our society. So I just want to thank you for your attention, and I look forward to the Q&A and answering any questions that you have about my path, as well as more specific questions around health equity. Thank you so much.
Thank you. I think this is the part where you would hear a lot of clapping. That was amazing.
Okay.
Thank you so much for sharing your story. I know we have students who are with us and who will watch the video, and I think it's often helpful for them to hear about our paths because they're not always straight. And definitely your passion comes across. So there's a tip, students. Find something you're really passionate about, and then you can really go out there and get that. Oh, and the third thing is, or the next final thing is, I think I want to be you when I grow up. That's amazing.
Thank you so much. Thank you. Yes, and I really appreciate Dr. Mebane, you mentioning that point about following your passion. Like when you wake up in the morning, you want to be excited about what you're doing, and if you're not, really like question, am I doing the right thing? Is it whatever I'm doing feeding my soul? And if it's not, then really considering, what that is, and pursuing that if you can.
Because one thing, I mean, you said so many things that I'd love to talk about, but when you were talking about not necessarily feeling supported, I mean, sometimes those are the clues that say, maybe I should step back for a second. Maybe this isn't working for me. And then you think about what you want to do next. So as a kickoff to the Q&A, would you tell us a little bit more about the sort of approaches or techniques you use in terms of helping organizations with equity?
Sure. So there are a few different things. So one really important aspect of like anti-racism work is just ensuring that everyone has like a baseline understanding of like foundational concepts. Because when we, for instance, say racism, people have different understanding of what that is. They think it's just like being mean to people who are like from a different group than your own. Versus the idea that, there are different levels of racism, there's interpersonal, there's structural, there's institutional, and really bringing a power analysis to this. Like a lot of times, sensitivity trainings or tolerance trainings, they are focused on not really changing the individual or challenging the power structure. So with my trainings, we bring a lot of that power analysis in so that people can really understand who are making decisions within organizations. Are these, how are we being accountable to the communities that we serve? So I do a number of virtual trainings, and then organizational equity assessments, really doing a deep dive with organizations, talking with all of their staff across the organization, reviewing policies, understanding what is the organizational culture there with respect to equity, what's going on with hiring, promotion, advancement. Are they looking at, trends? Are we seeing that Black people, Latino people, aren't being promoted at the same, level as, their white counterparts? And then producing report of the findings and recommendations that they can use as part of an organizational equity action plan. So I would say those are the main things. And the thing with the training, it's so important to have a shared sort of language and understanding and analysis around these issues before like embarking on some of this work, because so that everyone knows what racism is and what that looks like within an organization. Everyone understands what white supremacy culture looks like in organizations. And a lot of times the culture stuff, it's so embedded that you don't even realize until you're actually like talking. You're like, wait a minute. Yeah, I see that. I noticed that. But a lot of times it's like the air we breathe, or the water we're swimming in, we don't really notice what's around us until we like stop and reflect.
I think I had a recent experience with that. I went to a physician, sort of typical Black woman experience. She immediately jumped to some conclusions the first time I talked to her. And it wasn't until later when I thought, well, why did she do that? So there's something going on there that wasn't about what I was presenting, I think, in terms of being a patient.
Right. And that happens so much. And I just have to say, I had a medical procedure yesterday, and I cannot express how relieved I was when I learned that one of the doctors on the team was a Black woman. It was the anesthesiologist who came to greet me first. I could feel and I'm like I'm a healthcare professional, and I get it. And I could feel my body like literally relax. Like I felt like spaghetti, like when I saw her, and she talked to me with such care and attention and concern. I just felt like I was like, it allayed all my fears. So I can appreciate what you're saying.
That's great. So again, for the folks who are joining us, if you have a question, please do put it in the chat or share with us, and we will be sure to share it with Dr. Blackstock. So Dr. Blackstock, as you have done the work that you have on health equity, is there something that you've learned in the last year or two as we've come out of the pandemic and you formed your own LLC, which is amazing, about sort of what the challenges are and maybe even high spots, like where are people doing things that are actually working around anti-racism and equity?
Yeah, I would say just first, like a lot of my, and I this kind of I was giving a broad overview, but a lot of my inspiration came from work that Dr. Mary Bassett, who's now the health commissioner. She's a Black woman. She's a health commissioner for New York State, but she used to be the commissioner at the New York City Health Department up until a few years ago. But she started an initiative called Race to Justice at the New York City Health, at the health department a few years before I joined. And they have done there's a lot of work that needs to be done, but a lot of transformational work. And so sort of like what I was saying, a lot of times we are often focused on like, addressing health inequities in the community, but a lot of times it stems from like, all of these systems and racism existing within the organization. So, so some of the work that I've learned is really about like, how do we support community-based organizations that are the ones who are primarily in community health centers that are primarily, that are based in the communities that are most impacted. How can we prioritize those? Because what often happens is organizations that are successful at getting these grants are often the ones that are not led by people who look like us. And so it means sort of changing the criteria that we use to fund organizations. So like giving extra points for organizations that are led by people from the communities that are most impacted by HIV. Giving priority to organizations that are physically located in these communities as opposed to like in Manhattan, in Midtown, because that's basically what ends up happening. Those are the organizations that get funded. So it's just, a lot of it has been around centering the communities that are most impacted, and also just calling out these systems. So we often talk about poverty and lack of access to care and all these things like they just exist in a vacuum. But how do we tie these to these systems of racism, capitalism, all of this? So some of it's just bringing an awareness and being more explicit about the roles of these systems. And we do that in our, when I was at the health department, in our when we would have an RFP, I said, we need to start calling out these systems and we need to prioritize these organizations. And these are the populations that we need to be prioritizing. A lot of programs would end up, we would say this is a program that's supposed to be supporting Black and Latino people, but then like half the people would be like white people. So I'm just like, we need to really hold organizations accountable to serving the communities that most need, that are being most burdened. So that's some of the work. There's a lot going on, I think, in healthcare. I mean, there's some work around race, the practice of race-based medicine. I have colleagues who are working to get rid of, for instance, I don't know if people have heard about race adjusting for kidney function. So the way that kidney function is measured, there's an adjustment that has been made over the years for race, where the calculation that happens if race is Black and that's put into the formula, that underestimates the risk of existing kidney disease and makes Black people less likely, for instance, like if they need a kidney transplant, to be put on a kidney transplant list. So many colleagues that I have in this field are working to do away with these non-evidence-based race-based medicine like protocols that are being used. So that's some of the work that's happening. And I think a lot of what's happening is also just around training of leadership, of providers. There are studies that show that medical students, doctors in training believe that Black people feel painless, that our skin is thicker. I mean, this is like not 20, 30 years ago, this is like now. So a lot of schools are really working, medical schools, healthcare systems are really working to address these racist and preconceived notions around, whether Black people experience things differently than other groups of people.
That's great. Thank you so much for being specific. I think it's such a huge topic. I think sometimes, especially students, for example, might say, well, wait a minute, I can't do much about that. So it's really great to hear the concrete policy, advocacy, training, examples that you provided. So thank you for that.
Sure.
I do have a question here. What advice would you give to students who want to pursue a career in medicine or nursing or public health and might have this as one of their sort of priorities, for example?
Yeah, I would recommend if there's someone that you've identifying or someone that you've seen talk or someone who's doing something that interests you, that you might ask them if you can shadow them, if you can spend time, even just talk with them about how they got to that point, what their path has been, what their day-to-day work life is like. I think just having people are often very happy to talk about themselves and their past. So often people will say yes. But picking someone who looks like they're really interested and excited about their work they're doing can be helpful. And then again, obviously shadowing if they're like, sometimes there are opportunities like summer programs that allow for greater access to like the healthcare setting or the public health space for students. That those programs, there are many programs like that. There's also a mentoring in medicine program that's based here in New York, and I can see if I can. I'll try to Google as we're talking. That is specifically for Black and other students of color. That is really about connecting folks to mentors so that they can learn more about public health and healthcare. And just to say that, like, often, I'm a physician, so I'm just talking about like from a physician's perspective, but within health and healthcare, there's so many roles that people can have, and we're having more team-based approach to care. So you can help people as a physician's assistant, as a nurse practitioner, as an epidemiologist. Like there's so many different roles that contribute. It's not, there is physician supremacy, which is like a real thing. But just to let folks know that there are many ways to contribute to the health of their communities.
Thank you. Well, I know it's the real thing because I'm trained in public health and there's always that tension, but it's fine. We're all doing what we can to contribute. We need all of those perspectives anyway.
Yes.
So what advice also, so we're about to create a Master of Public Health degree here at Norfolk State University with a focus in health equity. What piece of advice would you give to us as we're building that curriculum and, taking the opportunity maybe to upfront avoid some of the racism that might be there, or to, directly train people who are culturally competent and have that as an emphasis? Yeah,
that's a great question. I think like one of the things that's really important is just like, a lot of times when we're in school or in training, we sort of like learn things in a vacuum and not how they're linked to each other. So I think like always really centering like the applicability of this to like community, to public health practice, like in the community is really important. And so bringing in examples, bringing in like community leaders, like I think all of that is like incredibly important. And I would also say that, there's like strange public health that's happening right now. Like I want people to understand like the pandemic, like, some of these recommendations about like no mask mandates, like a lot of this stuff is not based in public health, and public health is really about recognizing our interconnectedness to one another. So I think like any public health school should really be focused on like community health, like the health of communities and populations, and the way that our lives are interconnected with one another. There's a lot of healthcare and medicine tend to be very individual focused, and our culture tends to, core value of our culture is about pulling yourself by your bootstraps, individualism, all of that. But the ways in which, our faiths are really interlinked, I think is like really important. And it feels like kind of like I'm being like kind of woo-woo, but like, I think that that's really important approach to public health. Like we are all connected. And I think also, always having a structural analysis to problems, like being what are the policies, historical and current, that are impacting and causing the inequities that we're seeing, like always being like, what is underlying this? What are the structural determinants of health? We also often talk about social determinants of health, but we don't talk about what are the systems that lead to adverse social determinants of health? What leads to the fact that we don't have universal healthcare in this country. Like we have people who are homeless. Like, what are the factors? What are the systems that are driving these outcomes that we're seeing?
Helping to set the priorities, the
Yes.
allocation of funds,
Yeah.
and all of that. So just to shift gears just a little bit. So you did talk about you having a major shift in your career to being an entrepreneur. What do you do this is, about Black health and wellness for Black History Month. So what do you do to have a little balance on the more personal side, for example?
It's so important because, we have a culture that is like a grind culture that doesn't really prioritize individual or collective well-being. So I try to meditate most days. I'm a big Peloton fanatic. My sister got me into Peloton, so I ride the Peloton bike. I work out. Up until recently, I was also doing a lot of yoga. And I also I think exercising the creative part of our brain is really important. So I actually, I take voice lessons. I sing opera and jazz. And so actually just had a lesson a few hours ago. And so that's it's just really important for me. It's it's just so different from everything else I'm doing. It's kind of like just a nice escape. And I was just singing Summertime with my teacher. And, it's nice. I'm proud of myself to that I'm not just focused on my work, that there are these other things that, bring me joy and make me happy. It can be a little tough to balance things, but it's so important to have that balance.
Now, see, you shouldn't have said that, because do you take requests? Never mind. I did that. I'm not going to put
I don't think you want to hear me.
Never mind. So I do have another question here from our audience. Has the pandemic helped decrease racism or increase its presence in the healthcare industry, medicine, healthcare? And then I might throw in, it's not just, has it increased, has the perception of it changed? So
it's so interesting, because just even before I respond to that, I remember there was this a poll that was done recently, around Black Lives Matter and how many people feel like that's a priority. And it's, there was George Floyd's murder by the police, the social uprisings, there was increasing awareness around these issues, and then it's plummeted. And so, I do think I think there's some fatigue taking place, just in terms of people's willingness to speak on these issues, and potentially including within healthcare and public health. Although I think because healthcare and public health, these are healing professions, really about community. I do think probably compared to any other sector, and I may be biased because I'm, this is the work that I do think that there's the most sort of action and movement going on within healthcare and public health versus other sectors with respect to working towards racial equity and racial justice. There's obviously tons of work that needs to be done, but I also could be in a vacuum because I'm kind of surrounded by other people who do similar work as me. But I do think that it has definitely raised, and as you were saying at the beginning in the introduction, it's raised awareness. There's been a spotlight. It's really amplified the attention that's been put on health inequities. I just don't know. I don't know. I felt kind of a little bit hopeful, but I don't know how much change we'll ultimately be seeing, because these are really intractable. These systems are so deeply embedded in every aspect of our lives and of the public health and healthcare systems. So.
But you still do the work, though.
Yeah, we still do the work.
Go ahead.
No, just saying, I think this is
right.
You can think of it's multi-generational work. This is it took us, centuries to get to this point, and it's going to take, centuries to get to justice probably. But so we have to keep on pushing. And I think even, we have to get even some of the small wins and celebrate those, but, keep our eye on the future.
Because I was actually going to ask you that, whether you thought it definitely seemed to be a momentum in terms of money going to these issues, talk in the media that we haven't had. So I've been in public health for 30 years. And so And it ebbs and flows. And this seems to be a moment, but the question is, are we going to be able to sustain it and really have an ongoing? I hope it won't take 100 years. Hopefully we can disrupt and get it going a little faster. But it does seem like there's a moment here to take advantage of.
Yes. And I have to say that, I did a training, I think it was last week with staff at a psychiatric hospital up in Massachusetts. And it was a primarily white audience. I think there was one maybe Latino person, and I was super impressed with just the level of understanding of these different dimensions of racism, how structural racism operates. I feel like when people are exposed to this information, I think that they get it. We just need more of this happening. But it definitely made me helpful. It was a whole bunch of young white people, and they were like, "Oh yes, blah, blah, blah." And I was like, "How do you know this?" That was like, this is positive. I'm hoping to see more of this.
Right. Thank you. I mean, I have a fascination or interest in the intersection between popular culture or the arts and public health. Right. And you can see a shift in the kinds of stories that are featured. And I mean, people talk about, they have characters who have HIV and they talk about how they're able to live healthy lives. We weren't having those kind of public discussions. So I think there are shifts in the narratives and the stories that, that can lend itself to people from a variety of groups, learning and thinking differently about how they treat people.
No, definitely. And I was wondering, what show did you see with, they had a character with HIV?
So actually, I was binge watching on Netflix, The Designated Survivor.
Oh, okay.
So it was only 4 years, only 4 seasons, but they had a Black man who was HIV positive and had a partner, and then went through the whole thing of didn't tell him in advance, but my count is not, et cetera, et cetera. I don't remember the terms, but so there was a full-on discussion about the whole dynamic between the couple, but also, how they're treated, and also the medicines that are there to benefit. And I think it ended in 2018-19, okay. So it's relatively recent.
Oh, that's exciting. Okay, because that's great to hear. Because I mean, I think we know Pose and what's his name? Billy. What's his name? I can't remember the
Porter.
Billy Porter, right? And he's someone who was in the arts, in a creative field, and he didn't even feel comfortable disclosing his diagnosis of HIV. So it's positive development to hear about storylines where people living with HIV, but they're also dealing with a whole bunch of other things as well.
Mm-hmm. So another question is, and I'm sure you can relate to this because of your advocacy work in general, but especially as people of color, sometimes it's tiring, right?
Yeah.
To constantly notice, racist behavior, either locally or on the national level or whatever, and to be fighting against it. So what can we do? Because we were sort of saying a little bit that sometimes there's a long arc to the justice, right? So do we stay strong? Do we shift gears? What would you say about that fatigue that people can have in this space?
Yeah, I think staying present, just kind of being in the moment. It can be often we are thinking about, okay, what's going to happen? What are we going to do? Whatever. But I think just being in the moment, being what am I resourced for? What am I able to do at this time? I think, obviously we are trying to fight against these systems at the same time that we're experiencing the negative impacts of them. Mm-hmm. And so obviously we can't be go all the time. So it's just, a lot of it's, checking in with ourselves. When we are feeling like our cup is full, pushing forward. If we need to fill our cup, taking a break. But this is work that, obviously it's not just up to Black people to dismantle, system of racism, mm-hmm. Which really we need. It really is critical to have white folk and other non-Black people of color to do this work too, so that the burden isn't completely on us.
That's great. Thank you so much. So we're coming near about 7:30. So I think I'll have one last question for you. Again, we are very focused on our students here. Let me see, actually make sure that I'm covering it. Okay. So what would be any final words for our students out there who might, want to focus on these types of issues? And I want to say particularly because I'm an introvert I know it might be hard to imagine. I never thought of myself as an advocate who would go out and do things, but I'm very passionate about these issues.
Yeah.
So what advice would you have for our students in closing about how they might have an impact even now in different ways?
Yeah, no, I think the great part is that no matter like what your role is, whether you're a student, whether you're someone who's had a, several decades long career, there's always ways to contribute. And so some of it may be also like finding organizations. For instance, APHA, I think they have like, the Black Workers, Public Health Workers Caucus. Like there are different organizations. Like I'm part of a health worker advocacy group. So we do a lot of, I can't always be available, but we do a lot, like the global vaccine equity work that I've done. When I'm available, I will go and I will speak. But just to say that there are organizations that are doing advocacy around public health, around healthcare, that students can definitely be involved in, and they can be as involved or as little involved as they want to. So I would look for existing organizations within and just everything's virtual now, honestly. So it doesn't even need to be within, their city or their state. There's AMSA, the American Medical Student Association. That's when you're a medical student, but there's, APHA, as I mentioned. There are, let me think, there are a number of other organizations that students can be part of so that they can, learn how to be advocates. We have a number of organizations here in New York City that are for students that are addressing anti-racism, that are addressing issues around segregated care, how we have hospitals that don't take patients who have Medicaid or who are uninsured. And so students are speaking up, they're holding actions, they're doing virtual sit-ins, things of that nature. So there's lots of stuff that can happen, and that they don't have to do this alone. So that would be like my first piece of advice, would be to just look for advocacy organizations that are doing work that the student is interested in, and engaging with those organizations. And then also, there's lots of writing, for instance, writing op-eds. There's something called the Op-Ed Project, which is really about getting the voices of Black people and people of color and women out there. So I would recommend the Op-Ed Project. Just Google Op-Ed Project. If there is like a policy issue or just something related to health or well-being, whatever it is that they're interested in, that they want to write about, they've been thinking about, maybe they may have already have a draft of something, they can get assistance on writing an op-ed and figuring out where they can publish it. So there are, I think, a number of different ways that students can be involved.
Thank you. Thank you so much. This has been so exciting. I was inspired. I'm pretty confident our audience was inspired too. We thank you so much for joining us today and sharing your story. That was amazing. I think it is so helpful for people to be able to connect with you, as well as the work that you're doing. So we appreciate you doing that with us as well.
Thank you so much. Thank you, Dr. Mibin, and thank you, Dr. Miller, for the invitation. And my website is healthjustice.co, healthjustice.co. If you want to learn more about the organization and the services, great, thank you, and the services that we provide.
Perfect. And also with the Center for Public Health Initiatives here at Norfolk State, we have a new website or new web pages. You can go to nsu.edu/public health or public-health. We will put a link to her, some of her work there, as well as some of the organizations that she referred to that students can be involved in to do some of this work and to make connections to what we've been talking about. So again, thank you for joining us, and we look forward to seeing you guys at some of our other Black History Month events. Thank you.
Great, thank you. Bye, everyone.